Welcome back, everyone. For this lecture, we're going to take a deeper dive into the respiratory system with looking at advanced respiratory physiology and acid-base balance. Remember that when we're talking about respiration, there are two types of respiration that we refer to. The first being external respiration, which is the exchange of oxygen and carbon dioxide between alveoli and blood in the pulmonary capillaries, and internal respiration, which is the exchange of oxygen and carbon dioxide between systemic circulation and the cells. Respiration in general is that process of exchanging oxygen and carbon dioxide. And as we remember from anatomy and physiology, oxygen is required at the cellular level to ensure the production of ATP through glycolysis in the Krebs cycle. And waste products like carbon dioxide can have significant impacts on the body's pH and overall homeostasis. When we talk about pathophysiology of respiration, we are talking about things like the disruption of pulmonary ventilation, oxygenation, or respiration, and those causes can have immediate effects, and we as the advanced level providers and basic level providers need to be able to recognize those disruptions and correct them immediately. A term that you will note is common in medicine and emergency medicine particularly is that time is critical. Within as little as 60 seconds of hypoxia, we can see things like cardiac irritability, with brain damage being possible in as short as 4 minutes, and with lengths of time greater than 10 minutes, we may indeed see irreversible brain damage. So ensuring that we have adequate oxygenation, ventilation, and respiration is going to be critical to taking care of our patients and recognizing quickly. This is part of the reason that all of our assessment algorithms start with that airway, breathing, and circulation piece. Every cell needs a constant supply of oxygen to survive. And in order to ensure that every cell has a constant supply of oxygen, we need to make sure that we have adequate perfusion. So that's where the pulmonary and circulatory systems work together to make sure we meet those cells' needs. When we talk about the cardiovascular system and the pulmonary system not working in concert together, so for example, if the heart is not adequately flowing blood to the pulmonary capillaries, or ventilation is occurring without oxygenation happening, and it's unable to exchange oxygen at that cellular level, then we call those things ventilation-perfusion mismatch. And this is often referred to as the ventilation-perfusion ratio, or VQ is what it's referred to as short. And in essence, what this means is that air and blood flow must be directed to the same place at the same time for these systems to work together. Ventilation and perfusion must be matched together. There is numerous pathologies that exist where this isn't occurring appropriately, where the ventilation and perfusion aren't matched or mismatched. And this is referred to as a VQ mismatch. And this can be when the blood passes over the alveolar membranes without gas exchange occurring, or when CO2 is recirculated into the bloodstream, or perhaps when blood is not passed over an area in the lungs that is being adequately ventilated. In that case, we would refer to that as a shunt. Some of the factors that can affect ventilation leading to this ultimate VQ mismatch that we were discussing are things like a patent airway. A patent airway is critical for the provision of O2 to get into the lungs first and foremost, and then be onboarded onto the hemoglobin and delivered to the cells. There can be factors that that affect ventilation, including intrinsic factors and extrinsic factors. One of the primary factors that we talk about in airway occlusions, or preventing air from getting into the lungs, is the tongue as an airway obstruction. This is the most common airway obstruction, and we learn how to address this airway obstruction as EMT basics with the head tilt chin lift or jaw thrust maneuver, or using simple airway adjuncts such as OPAs or NPAs. These are effective in pulling the tongue away from the hypopharynx and the oropharynx and allowing air to pass through appropriately. Other factors that can affect ventilation are intrinsic factors such as things like allergic reactions or infections or unresponsiveness. Again, the tongue is the most common airway obstruction, but you can see here from a laryngoscopy video of some swollen tissue of the glottic opening. You can see how this swelling that can occur through infection or anaphylactic reaction can ultimately inhibit the passage of air into the lungs for that gas exchange to occur. Those were all known as intrinsic factors, factors that were originating from within the body. We also can have extrinsic factors that inhibit adequate pulmonary ventilation. Things like trauma or foreign body airway obstructions can mechanically occlude those ventilatory spaces. You can see here a patient with significant facial trauma and facial swelling. Ultimately, the patient had to have a breathing tube placed in the throat or a cricothyrotomy so that those structures were bypassed to allow adequate ventilation. Oftentimes, trauma requires immediate interventions, and so you need to be vigilant and diligent as a provider in assessing a patient's ability to maintain their airway, because without a patent airway, no ventilation can occur and subsequently no respiration can occur. There are also some other external factors that can affect oxygenation and respiration more specifically. So factors in ambient air, for example, high altitudes or closed environments, the oxygen level decreases as altitude increases. And so while ventilation may be adequate, there may be an inadequate supply of oxygen so that the respiration can occur, the external respiration in the alveoli. There's not adequate oxygen there for that gas exchange to take place. You also have considerations where toxic gases can displace oxygen within the environment. Carbon monoxide is one that comes to mind here, as carbon monoxide is significantly heavier than oxygen and will settle at the lower levels and ultimately fill a room, displacing oxygen out of the environment so a patient doesn't have oxygen to gas exchange with. Ventilation may still be fine. The airway may be patent, but there may be an inadequate supply of oxygen for respiration to occur effectively. There are also conditions that can affect oxygenation and respiration, so things like pulmonary edema or fluid in the lungs. This is where gas exchange may be occurring in the functional areas of the lungs, but these non-functional alveoli that are inhibited by fluid buildup, diffusion isn't occurring, and this can prevent that external respiration from happening. There may be a patent airway. There may be at least moderately adequate ventilation, and there may be an adequate amount of oxygen in the inhaled air. But there's a mechanical disruption here that prevents that external respiration from occurring. This is common in, as mentioned, pulmonary edema, or even submersion victims, or victims who have had an exposure to environmental conditions or occupational hazards where they've inhaled a toxic substance that has damaged the alveolar tissue. Some other factors that can inhibit internal respiration and oxygenation, things like hypoglycemia. A patient who is significantly hypoglycemic may not have an adequate amount of sugar to appropriately metabolize and create adenosine triphosphate, may have a reduced respiratory compromise or reduced respiratory effort rather. Things like infection may increase the metabolic needs of oxygen for a patient. So they may have inadequate oxygenation even though under normal circumstances, the supplied amount of oxygen and ventilation is adequate. Or things like hormonal imbalances, things that can result in things like ketoacidosis. Circulatory compromise can also play a significant role in the inability of the cells to become oxygenated. If there's inadequate perfusion, ultimately oxygen demands are not going to be met at the cellular level. We can onload the hemoglobin with as much oxygen as we want. We can ventilate adequately. We can put them on 100% O2. We can even intubate the patient. But if the patient doesn't have adequate blood flow to the cell, all the oxygen on the hemoglobin doesn't help the cells oxygenate. And remember that our metric for oxygenation is not to see how much of the cells we can saturate, but if the oxygen doesn't make it to the tissue, they're still hypoxic. The patient is still suffering. The tissues are still going to die. So we need to be vigilant about assessing for circulatory compromise as part of looking at even the respiratory and particularly pulmonary patients. Heart conditions exist that can reduce blood flow to tissues. Things like blood loss during anemia reduce the oxygen carrying capacity of the blood. Shock, states of hypoperfusion, right, When the tissues aren't being adequately perfused, they're not getting oxygen. They move into a state of anaerobic metabolism, which, if you'll remember again from anatomy, that produces less adenosine triphosphate and causes a significant buildup of metabolic byproducts that are further harmful to the body, things that shift the pH in one direction or another. One of the tools that we can use to assess the body's ability to not only oxygenate, ventilate, and engage in respiration, cellular respiration, is the assessment of end-tidal CO2 or capnography. The benefit of using end-tidal CO2, while it doesn't directly tell us how much of the hemoglobin is saturated in oxygen, we have other tools for that, such as SpO2. Measuring the end-tidal CO2 really tells us how well the body is being oxygenated and if the body's cells are able to adequately use that oxygen to produce ATP, because CO2 is a byproduct of cellular respiration. So that CO2, that presence or absence of CO2, tells us how well the body's doing with metabolizing oxygen and glucose and ultimately producing those metabolic byproducts. Now we'll get into CO2 a little bit more in depth as well. It also tells us other things, such as by looking at the waveform and waveform capnography, things like bronchial spasms or lower airway constriction based on that waveform. It also gives us an adequate way to assess the amount of minute volume or ventilatory volume per minute for a patient. Our target in a healthy metabolic patient is between 35 and 45 for an end-tidal CO2, and it should have this sort of capped waveform that you see here on the screen. If patients are ventilating with a normal minute volume, that is anywhere between 5 and 6 liters a minute, so roughly 500 milliliters per breath, 10 to 12 times a minute, and their CO2 is excessively high, they may be in a state, or they will be in a state of hypercapnia. And if that's accompanied with normal ventilation, that's some indications of some metabolic issues that may be arising. Likewise, if they're in a hypocapnic state, or the CO2 is too low, with a normal minute volume, that may also indicate some underlying pathology. If we don't suspect an underlying pathology, though, we can use end-tidal CO2 to help us drive the rate at which we need to ventilate patients. If we assess on the front end with SpO2, for example, and we're saturating at 98%, and we're ventilating the patient 12 times a minute per se with assisted ventilations, but their end-tidal CO2 is 60, they're hypercapnic. And that means we're not off-gassing an adequate amount of CO2. So we may need to speed up the ventilations slightly. On the alternative side, if we're ventilating at 12 times a minute and we don't suspect an underlying state of physiology, but their end-tidal CO2 is low, say 30, we may need to reduce that minute volume in ventilation for those patients to ensure that we're not excessively removing CO2. And CO2 plays an important role in the respiratory physiology piece, more than just how fast or how slow we're going to ventilate a patient or underlying pathologies that maybe exist. In fact, the body itself uses that concentration of CO2 to determine the rate of spontaneous ventilations within the body. And that's where it'll bring us to looking at acid-base balance and some of its importance. If you'll remember from anatomy and physiology, CO2, until it gets to the lungs, is dissolved in the blood. And CO2, when it's dissolved in solution, i.e. the blood, indeed makes the solution more acidic, or there is an increase in hydrogen ions. So it changes the pH of the blood overall. That subsequently changes the pH of the cerebral spinal fluid, and as we'll see here shortly, that pH is what drives in the brain how fast we breathe at homeostasis. So a disruption in CO2 can change significantly how oxygen moves throughout the body. The image that you see here on the screen is an image of the oxyhemoglobin dissociation curve. And I know that sounds like a lot of words there that are hard together, but we'll break them down just a little bit. Oxyhemoglobin, so when oxygen is bound to hemoglobin, and when it disassociates or when it removes itself from the hemoglobin molecule. If you'll remember, external respiration is oxygen being onloaded at the pulmonary capillaries onto hemoglobin. And then oxygen, when it gets to the individual tissue, needs to be offloaded into the cell to be able to engage in cellular respiration. The oxygen hemoglobin or oxyhemoglobin dissociation curve describes the tendencies in which oxygen tends to associate with hemoglobin, like in the pulmonary system, or disassociate with hemoglobin at the cellular level. If you'll notice, one of the primary driving factors in this, in shifting the oxyhemoglobin curve to the left or to the right, is the amount of pH. Oxyhemoglobin in a decreased pH setting, a more acidic setting, has a higher affinity. That means that in the lungs, the slightly higher concentration of hydrogen ions or lower pH drives more oxygen onto the hemoglobin. While at the cellular level, there's a slight change in pH. There's more hydrogen ions, and that creates a shift for the oxygen to disassociate. So when oxyhemoglobin is disassociated to the left, we're seeing a decrease in hydrogen ions or an increase in pH. When it shifts to the right, we're seeing an increase in hydrogen ions or a decrease in pH. These subtle changes in pH significantly affect how well we can oxygenate the tissue, which is why it's important as we're ventilating these patients or assessing ventilatory status, that the patients are aware, or that rather we as providers are aware, of the ultimate changes that we can occur by ventilating too much or too little or impacting the pH overall. The respiratory and the renal systems work together to help maintain homeostasis. This tendencies toward stability in the body, or term of homeostasis, is a balance between acids and bases, or alkali. And the body uses both the renal system and the respiratory system to maintain that status. As we mentioned earlier, if the body detects too low of a pH or a high concentration of carbon dioxide, the brain will send signals to the lungs and diaphragm to ventilate more frequently. This will off-gas the CO2, resulting in an increase in pH. This subsequently will be taken over by the renal system and the production of things like bicarbonate to help maintain that long term. But those immediate changes and effects are done by the respiratory system. And oftentimes when we find patients with a prolonged downtime, they have a state of respiratory acidosis due to hypoventilation. But that can be eliminated and corrected, not by the use of medications like bicarbonate, but just by ventilating that patient for a period of time. Alkalosis can develop if the respiratory rate is too high. And we can look at these states as in respiratory acidosis or alkalosis. And these are states of acidosis or alkalosis driven by the respiratory system, or metabolic acidosis and alkalosis, changes in pH driven by the metabolic system. We'll discuss these concepts further as we look at specific respiratory pathophysiologies, but it's important to understand the relationship as an advanced provider between ventilation and respiration and oxygenation, and how all of that impacts the pH and homeostasis, and what effects those have on the exchange of gases like carbon dioxide, not only at the pulmonary capillaries, but at the cellular level as well.